Welcome to MedStudious. Today, we're diving deep into one of the most powerful and consistently examined topics across every major medical licensing exam in the world: fertilization and implantation. Whether you're sitting USMLE Step 1, MRCP Part 1, PLAB, AMC, or your MBBS professional examination, this single topic can silently make or break your score. Why? Because it doesn't test just one subject. It weaves anatomy, physiology, histology, biochemistry, and clinical obstetrics into one beautiful, continuous biological story. Every structure has a function. Every function has a clinical consequence. And every clinical consequence is testable. From the moment sperm enters the female reproductive tract to the moment a blastocyst buries itself into the endometrium and begins reshaping the maternal body, every step is packed with exam-ready information. This is not just embryology. This is the clinical blueprint of early human life. Stay with us, take notes, and by the end of this video, you will be able to map the entire fertilization to implantation sequence, explain its pathological detours, and answer any exam vignette that tests this topic with complete confidence. Let's begin. At the moment of ejaculation, approximately 500 million spermatozoa are deposited near the external os of the cervix, and yet only 300 to 500 of them will ever reach the site of fertilization. That is a survival rate of 1 in a million, and that number is a high-yield exam fact on its own. So what happens to the rest? The journey from vagina to ampulla takes roughly 1 hour, but it is a gauntlet. First, vaginal acidity destroys the majority of sperm immediately. Those that survive must navigate cervical mucus, which acts as a dynamic molecular gatekeeper. Here's the critical clinical pearl. Cervical mucus is not static. Under estrogen dominance at mid-cycle, the mucus becomes thin, watery, and forms parallel channels visible as a ferning pattern on microscopy, which actively facilitates sperm transport. But under progesterone dominance in the luteal phase, that same mucus becomes thick and impenetrable, hostile to sperm. This cyclical change is the physiological basis of mucus-based natural family planning methods and is a recurring theme in physiology exam questions. After cervical filtering, surviving sperm face immunological attack from maternal leukocytes, and a further fraction is lost by entering the wrong uterine tube. The small surviving cohort, now numbering in the hundreds, reaches the ampulla ready to meet the oocyte. Before we can understand fertilization, we must understand the remarkable biological status of the oocyte at the moment it is released. The primary oocyte has been arrested in prophase of meiosis I since before birth, potentially for decades. It is only the surge of luteinizing hormone at ovulation that triggers the completion of meiosis I, producing the secondary oocyte and expelling the first polar body. But here is the twist. The secondary oocyte does not complete meiosis. It pauses again, this time arrested in metaphase of meiosis II, and that is the cell that is actually ovulated. That is the cell sitting in the ampulla waiting for sperm. Meiosis II will only be completed if a sperm successfully enters and fertilizes the oocyte. If no sperm arrives, the secondary oocyte simply degenerates, forever frozen in metaphase II. This is a high-yield arrest and completion pattern that examiners love. Here is the exam pearl that trips students up. The ovulated oocyte is technically haploid in terms of chromosome number, 23 chromosomes, but it still contains 46 chromatids, because those chromosomes are still in their paired sister chromatid form. The actual reduction to a truly haploid state with 23 single chromatids doesn't happen until meiosis II is triggered by sperm entry and the second polar body is expelled. Sperm that reach the ampulla are still not ready to fertilize. They must first undergo capacitation, a critical functional maturation process that takes place over approximately 7 hours within the female reproductive tract. During capacitation, glycoprotein coatings are stripped from the sperm surface. Calcium ions flood into the cell, cyclic AMP levels rise, and the plasma membrane overlying the acrosome becomes destabilized. The result is hyperactivated motility, a dramatic, whip-like, high-amplitude tail movement that is mechanically necessary to penetrate the zona pellucida. This is step 1. Step 2 is the lock and key binding event. Capacitated sperm bind directly to ZP3, a specific glycoprotein embedded in the zona pellucida. This is the species-specific recognition step, one reason interspecies fertilization does not occur naturally. The binding of ZP3 triggers step 3, the acrosome reaction, in which the acrosomal vesicle undergoes exocytosis, releasing a concentrated burst of hydrolytic enzymes, hyaluronidase, acrosome, and neuraminidase, that chemically digest a path through the zona pellucida, allowing the sperm to reach and fuse with the oocyte membrane. The clinical relevance here is enormous. ICSI, intracytoplasmic sperm injection, bypasses all 3 of these steps entirely by injecting a single sperm directly into the oocyte cytoplasm, making it the gold standard treatment for severe male factor infertility, including cases of total acrosome reaction failure. Once one sperm successfully fuses with the oocyte membrane, the oocyte must immediately prevent any additional sperm from entering, a process called the block to polyspermy. There are 2 sequential mechanisms, and both are testable. The fast block occurs within milliseconds of sperm-egg fusion. The oocyte membrane undergoes rapid electrical depolarization, immediately changing its charge and making it temporarily inhospitable to additional sperm binding. This is instant, but transient. The slow block, also called the cortical reaction or the zonal reaction, is the definitive permanent defense. Cortical granules sitting just beneath the oocyte plasma membrane undergo exocytosis, releasing enzymes into the perivitaline space. These enzymes permanently chemically alter the zona pellucida glycoproteins ZP2 and ZP3, hardening the zona and physically preventing any additional sperm from binding or penetrating. When these blocks fail, dyspermy occurs. 2 sperm fertilize a single oocyte, producing a triploid embryo with 69 chromosomes. This is one mechanism leading to a partial Hydatidiform mole. Following successful single sperm fusion, the sperm head decondenses into the male pronucleus. The oocyte completes meiosis II, extruding the second polar body, and the female pronucleus forms. When the membranes of both pronuclei break down and their chromosomes align on a shared mitotic spindle, this is syngamy, the true moment fertilization is biologically complete, restoring the diploid count of 46 chromosomes. Triploidy, a cell with 69 chromosomes instead of 46, is one of the most high-yield abnormal fertilization outcomes on board exams, especially because it comes in 2 flavors, with 2 completely different clinical phenotypes that examiners love to contrast. The first is diandric triploidy, meaning the extra chromosome set comes from the father. This happens via dyspermy, 2 sperm fertilizing 1 normal oocyte, or via fertilization by a diploid sperm. The result is a conceptus with 2 paternal chromosome sets and 1 maternal. The clinical picture is dramatic, an overgrown, cystic, abnormal placenta. This is the pathological mechanism behind a partial Hydatidiform mole with a karyotype of 69XXY or 69XXX. The second type is digenic triploidy, where the extra set is maternal in origin. This happens when the secondary oocyte fails to extrude its second polar body, meaning the oocyte retains a diploid female contribution. The resulting placenta is small and poorly developed, and the fetus shows severe growth restriction, the exact opposite clinical picture. For completeness, examiners also test complete Hydatidiform moles, which are different, a 46XX genome that is entirely paternal, arising when a single sperm fertilizes an empty egg and duplicates its own chromosomes. Remember, complete mole equals all paternal. Partial mole equals diandric triploidy via dyspermy. Nailing this distinction is worth guaranteed marks on any obstetrics exam. After fertilization and syngamy, the newly formed zygote begins a precisely timed sequence of mitotic divisions called cleavage. The first division occurs at approximately 30 hours, producing 2 blastomeres. By 50 hours, there are 4, by 60 hours, there are 8, and by days 3 to 4, there are 12 to 16 cells. One of the most conceptually important facts about cleavage is that the total volume of the embryo does not increase. Each division simply partitions the existing cytoplasm into progressively smaller blastomeres. This is fundamentally different from ordinary somatic cell growth. By day 3 to 4, this solid ball of cells, now resembling a mulberry, is called the morula, and it enters the uterine cavity from the fallopian tube. Between days 4 and 5, fluid begins to accumulate between cells and coalesces into a single central cavity called the blastocoil. This converts the morula into a blastocyst, now clearly divided into two cell populations: the outer trophoblast, destined to become the placenta and fetal membranes, and the inner cell mass, or embryoblast, destined to become the embryo itself. Then comes a critical prerequisite for implantation: hatching. The zona pellucida, which has enclosed the embryo since ovulation, must break down and be shed before the trophoblast can make contact with and adhere to the endometrium. Without hatching, implantation is impossible. This is why assisted hatching is sometimes performed in IVF cycles. Monozygotic, or identical twinning, is not a random event. The type of twinning that results depends entirely on the precise timing of the embryo split, and this relationship between developmental stage and placental/membrane architecture is one of the most reliably tested embryology concepts across every major medical exam. When splitting occurs during early cleavage, days 1 to 3, before compaction, each embryo develops its own independent trophoblast, chorion, and amnion, producing dichorionic diamniotic, or DID twins. These are clinically indistinguishable from dizygotic fraternal twins on placental examination alone. When splitting occurs at the blastocyst stage, days 4 to 8, after the trophoblast has already differentiated, meaning the chorion is already committed, but before the amnion forms, the result is monochorionic diamniotic, or MODY twins. They share one placenta and one chorion, but each has a separate amnion. This is the most common pattern of monozygotic twinning and carries the highest risk for twin-to-twin transfusion syndrome. If splitting is delayed to days 8 to 13, after the amnion has also formed, the result is monochorionic monoamniotic, or MOMO twins, sharing everything, with the highest risk of umbilical cord entanglement and fetal loss. Finally, splitting after day 13, once the embryonic disc and primitive streak have begun to form, results in conjoined twins because separation is now incomplete. Remember, the earlier the split, the more separate the twins. For the blastocyst to successfully implant, the endometrium must be in a state of maximal receptivity, and under the influence of progesterone from the corpus luteum, it transforms into a specialized structure called the decidua. Understanding the 3 decidual layers is a classic histology exam item, and it also has direct clinical relevance for understanding placental pathology and labor. The most superficial layer is the decidua compacta, the compact gland-pore surface zone that the blastocyst first contacts. Beneath it lies the decidua spongiosa, the intermediate layer packed with dilated, tortuous uterine glands. This layer is anatomically critical. The decidua spongiosa represents the plane of cleavage along which the placenta separates from the uterine wall during the 3rd stage of labor. Defects in this layer, or abnormal invasion through it, underlie placenta accreta spectrum disorders, one of the most dangerous complications in modern obstetrics. The deepest layer is the decidua basalis. It contributes to the maternal side of the placenta and, crucially, contains the regenerative glandular stem cells that allow the endometrium to regrow after delivery or miscarriage. The clinical pearl here, in a standard 28-day cycle, maximal endometrial receptivity, the window of implantation, occurs around day 21. In modern IVF, the endometrial receptivity array, or ERA test, is now used to precisely identify each individual patient's personal implantation window and time embryo transfer accordingly. By days 7 to 9, the trophoblast differentiates into 2 distinct and functionally complementary layers, and understanding what each one does is essential for both embryology and clinical obstetrics exams. The inner layer is the cytotrophoblast, sometimes called the anchor. It is composed of mononuclear cells with distinct individual cell membranes. It is mitotically active, constantly dividing and feeding new cells into the outer layer to sustain invasion. The outer layer is the syncytiotrophoblast, the invader. It is a remarkable, functionally unique tissue, a multinucleated mass formed by the fusion of cytotrophoblast cells, with no distinct cell membranes between them. It is the leading edge of invasion, secreting powerful proteolytic enzymes that erode maternal tissue, burrow through the endometrial stroma, and ultimately tap into maternal blood vessels to establish the intervillous space. Crucially, the syncytiotrophoblast is also the source of human chorionic gonadotropin, HCG, which rescues the corpus luteum from luteal regression and maintains progesterone production, sustaining the pregnancy until the placenta takes over. The depth of invasion is not unlimited. It is regulated by a bidirectional molecular dialogue between trophoblast and decidua. LIFE and EGF promote invasion, while TGF-beta inhibits it. When this regulation fails, insufficient invasion leads to implantation failure, excessive invasion leads to placenta accreta, increta, or percreta. The normal 3 to 4 day transit time through the fallopian tube is critical. The embryo must be at the right developmental stage, a competent blastocyst, at precisely the moment it reaches the uterine cavity. If anything delays that transit, the blastocyst becomes implantation competent while still within the tube, and the result is ectopic pregnancy, a condition that remains one of the leading causes of first trimester maternal mortality worldwide. The most common ectopic site, accounting for the vast majority of cases, is the ampulla of the fallopian tube, the same region where fertilization normally occurs. Other sites include the isthmus, the interstitial or cornual segment, the ovary, the cervix, the abdominal cavity, and increasingly recognized due to the global rise in cesarean delivery rates, the cesarean scar. Risk factors for ectopic pregnancy all share a common mechanism: anything that impairs tubal transport, pelvic inflammatory disease causing tubal scarring, endometriosis, prior tubal surgery, smoking-induced ciliary dysfunction, or prior ectopic itself. The classic clinical triad is amenorrhea, unilateral pelvic pain, and vaginal bleeding. The key diagnostic tool is serial serum beta-HCG measurement. In a normal intrauterine pregnancy, HCG rises by at least 53% over 48 hours. A rise slower than this, in the correct clinical context, should raise immediate suspicion for ectopic pregnancy and prompt urgent ultrasound evaluation. By days 9 to 11, the blastocyst is completely embedded within the endometrium, and the embryo has triggered a cascade of changes that will establish the earliest uteroplacental circulation. As the syncytiotrophoblast erodes through the endometrial stroma, it creates a network of fluid-filled spaces called lacunae. These lacunae expand and merge, and as the eroding trophoblast taps into maternal capillaries and spiral arterioles, they fill with maternal blood, creating the lacunar network that is the direct precursor of the future intervillous space of the mature placenta. The entry point where the blastocyst penetrated the endometrium is sealed by a fibrin coagulation plug, which re-epithelializes over the following days. This is also the phase when minor implantation bleeding occurs. As the invasive trophoblast erodes small maternal capillaries, a small amount of blood may escape, presenting clinically as light spotting. This is a physiological event, but it is clinically indistinguishable from early threatened miscarriage without serial HCG measurement and ultrasound. Meanwhile, the syncytiotrophoblast has been secreting HCG since implantation began, now at detectable levels, signaling the corpus luteum to keep producing progesterone. This HCG-mediated corpus luteum rescue, the luteal rescue, is the molecular mechanism that sustains the pregnancy through the first 8 to 10 weeks, until placental steroidogenesis takes over in what is called the luteal placental shift. By the end of the second week, the inner cell mass has differentiated into the bilaminar embryonic disc, 2 distinct cell layers. The epiblast faces the newly forming amniotic cavity above. The hypoblast, also called the primitive endoderm, faces the blastocyst cavity, the future yolk sac, below. These two layers together form the scaffold from which the entire embryo proper will develop, setting the stage for week 3 gastrulation and the formation of the trilaminar embryo with ectoderm, mesoderm, and endoderm. But this slide also introduces one of the most clinically important concepts in teratology, the teratogenic windows. The first 2 weeks after fertilization, the pre-implantation and early post-implantation period, are classically called the all or none period. During this window, the embryo cells are totipotent and pluripotent. If a teratogen damages the embryo here, one of 2 outcomes occurs. Either enough cells are killed to cause miscarriage, or the surviving pluripotent cells completely compensate and normal development continues with no structural defect. True structural teratogenesis, malformations of specific organ systems, only becomes possible once organogenesis begins in week 3. This is why examiners asking about drug or radiation exposure in early pregnancy before a missed period often have an all or none answer. The window of real structural risk is weeks 3 through 8, the organogenesis period. This final slide is the master map, and it is worth spending extra time here to lock the entire spatiotemporal sequence into your memory. At day 0, fertilization occurs in the ampulla. This is also the site of triploidy via dispermy and the most common location for ectopic implantation. Days 1 to 4 are the cleavage and morula stage. The embryo is still in the fallopian tube, dividing without growing, marching toward the uterus. This is also the window in which early splitting produces dichorionic diamniotic twins. Days 4 to 8 bring blastocyst formation, zona pellucida hatching, and the risk of monochorionic diamniotic twinning if splitting occurs here. Days 6 to 11 represent the entire implantation window. The blastocyst contacts the endometrium, trophoblast differentiates, the lacunar network forms, HCG is secreted, and the corpus luteum is rescued. Defects in the spongiosa layer during this window underlie placenta accreta spectrum and implantation failure. By day 14, the bilaminar disc is established and the all or none teratogenic period ends. The bottom line and the exam principle that ties all of this together is this: in early obstetrics, pathology is physiology displaced. Every testable clinical entity, ectopic pregnancy, Hydatidiform mole, twinning variants, implantation failure, placenta accreta, is simply a disruption of this predictable, sequential, anatomically and temporally precise biological process. Master the normal sequence, and the pathology explains itself. Please like, comment, and share this video, and subscribe to MedStudious for more high-yield medical content.